in mantle cell, there clearly is a population that is appropriate for a sort of watch and wait strategy. That's probably 10 to 15% of newly diagnosed mantle cells. My approach in mantle cell is sort of first one to figure out if the patient's having symptoms and do they need some sort of treatment to address that immediately. And then I think some of the molecular markers of mantle cell are very important. Sometimes we'll often take a step with things like looking for p53 mutations or checking whether or not a mantle cell looks like it's a blastoid variant, because that helps further define, that they're not a sort of indolent mantle cell kind of population. I think beyond that, sometimes it's a clinical judgment, and then also based upon some of the pathology markers, namely SOX11 seems important for determining whether or not there's this kind of indolent mantle cell variant that you can observe for a period of time. But really, the literature shows that there's no you don't lose anything for trying to observe these patients for some period of time, and especially in patients that turn out to have indolent disease, I think that's very valuable to save them months, potentially years of treatment-free time before you end up having to treat them either with chemotherapy or novel agents with side effects.